So as the chair for the department, COVID was definitely a challenge, and we had to do a lot in the department to be prepared. It turns out that New York City became the epicenter of the epicenter before we realized it. So I'm going to take you guys through a journey of kind of what we had to do to prepare ourselves, the numbers of patients we had to take care of during COVID. And I'll sprinkle a little bit about what it means to be a chair and what the responsibilities are to be prepared for something like COVID. So this is data from June 3rd. This data has since changed somewhat. Um, total cases worldwide were 6.4 million. Total deaths 380,000 or so. So about a mortality of 5.9%. Cases in the US, again, these numbers have not been updated since June 3rd. A total of 1.8 million cases. So we had about 28.1 of the worldwide cases here in the US. And we had 27.6% of the worldwide mortalities. Getting closer to home, in New York State, we had a total of 368,000 cases, which made us 5.8% of the worldwide cases here in New York State. So we had 20.5% of the US cases here in New York State. The total deaths, as you can see, of the US mortalities, we had 28.3% of those mortalities. These are huge numbers. When you drill down to New York City, you'll see that we had a total of 200,000 cases, and we had 21,000 deaths. The epicenter of the epicenter turned out to be Queens. As you can see, there were 62,000 cases in Queens. Kings means Brooklyn, at 56,000, and the Bronx had 45,000. So the question is, why did Queens and Brooklyn have many more patients? There's a lot of speculation, but what we know is that there is some involvement with the socioeconomics that impacted this. There's also cultural reasons that this may have happened. So let me explain. So when we put shelter in place, which was a good process, that was a process to tell folks to stay off the streets, off the subways, stay home, to protect yourselves and your loved ones from the virus. For some people, that meant that there would be multiple people in a small apartment of sorts, or maybe a home, but with multiple people. And if one person was an essential worker and had to go to work, that person would go to work, get on the subways, and potentially come home and inflict COVID on the members at home. So if there were several members in the household, everyone became sick. So that was something that we noticed in Queens. There are also cultural reasons that many folks, in many different cultures, it is never a thing to send grandma or grandpa to a nursing home, that multi-generations of family live in the same household. So that also created a situation where if one person became sick, the entire household became sick. So I also do work in Queens. We have a hospital, Forest Hills, and we saw a tremendous amount of cases because of this. And going down to Northwell Health, we work as part of a large healthcare organization that has 20 plus hospitals. Long Island Jewish Forest Hills, which is in Queens, and LIJ Valley Stream had a majority of the cases. And this goes back to my discussion about Queens and the fact that multiple people live in the same household. You can see that Northwell Health took care of 45,000 folks with COVID. So at some point during COVID, we actually had more than 1% of the worldwide cases were here at Northwell Health. 2.5% of the US cases and 12% of all cases in New York State were managed here at Northwell Health. So a tremendous amount of burden for our hospitals. So how did we manage this? Because we were part of such a large area, Long Island and New York, we had to move patients to hospitals that could accommodate the patients. So for example, Lenox Hill, where we work here, we took 200 plus patients and we transferred them from Forest Hills Hospital and LIJ Valley Stream to be able to accommodate them. Otherwise, those hospitals would not be able to manage that large volume of patients, and it would be unsafe. There was one Sunday, the third week of March, where the EMS system in New York State was overwhelmed with the amount of calls that they received. Typically on that Sunday, they may receive 2,000 calls. That day, they received over 6,000 calls to transport patients to hospitals. The system was overwhelmed. You could see here, this graph, what it represents was the testing that we would do for patients who came to the emergency department for COVID. We saw our first case around March 7th. And as we tested folks during this pandemic, at some point in the peak, you could see the first week of April, for every patient that we tested, 57% of them were positive for COVID. So that's 1 out of every 2 patients that walked in was positive for COVID. As we plateaued, you could see the numbers started to diminish. Right now, I'm happy to say that the hospital has less than 5 patients with COVID in the hospital. It's a major, major success from where we started. So how did we do this? The operations. So that is part of my responsibility. How did we manage so many patients, so many sick patients? We had to make some very quick changes in the emergency department. We converted some spaces that were curtained areas that we knew that would not be safe to manage patients with COVID into some closed spaces. And we did this construction literally overnight. We took some additional space in the hospital, the PACU. That's the place where they recover patients who have just come out of surgery. We took that space and we put patients who were non-COVID in that area. And the main ED, we took care of patients who were COVID positive. We wanted to separate the patients so that patients who didn't have COVID wouldn't contract COVID while being here in our emergency department. PPE, you guys will hear, that's the protective equipment that we use, the masks, the gowns, the shields for the eyes. We had issues, and you heard of issues where hospitals were running out of this. Because we're part of such a large healthcare organization, we're really able to take control of that and make sure that we had enough supply for all our staff. I mentioned to you guys also that we accepted patients from Forest Hills and Valley Stream. We transferred the most amount of patients to us here at Lenox. To mention also the social economics and how it plays into all of this. Lenox Hill is located in the Upper East Side of Manhattan, which is one of the most affluent areas in the world, you could argue. We're the only hospital on Park Avenue. So folks who live in this area some of them had the luxury of being able to leave the area and go to Eastern Long Island, to go to Connecticut, to go other places where they had homes and space. And what that did was that we didn't have we had less patients that we would normally have from this area, which was a godsend. It was very fortuitous for us. That allowed us to have some capacity to be able to take care of the patients who weren't so advantaged out of Queens. This was very difficult for our staff. The community support was fantastic. We had so many donations in terms of food and supplies and support from the community. The 7 o'clock clap. This was a welcome surprise, and this was very necessary, but because the stress of having to take care of COVID patients was overwhelming. It was overwhelming for the doctors, the nurses. Can you imagine that you have to take care of patients that you know that you may potentially get the virus as you're managing the patients? And that did happen to some of our nurses and some of our doctors. But luckily for us, they all did well, but some of them did get very sick with COVID. So again, it was a very stressful time for everyone. But as part of my job and responsibility as the chair, I had to help people through the stress and keep the morale up and keep everybody engaged and motivated to do the best work that they could, even despite the fact that they were stressed and concerned about their own lives and the lives of their loved ones at home. We're going to mention something called our patient callback system, because it turned out that we could not admit all the patients with COVID. Some of them were sick, but not sick enough to be in a hospital, and we had to send them home. But we had to do that safely, and we're going to discuss how we did that later. The other thing we had to do is we had to change the schedule of our doctors so that we had multiple doctors at once. With COVID, as you saw the graph, when we plateaued, there were times we were taking care of multiple COVID patients, very sick patients at the same time. So I had to make sure I had enough physicians and nurses to do that. We also had to have a sick backup call. True story, during the care of our patients, one of my doctors actually said during a shift, I have a fever and I don't feel well. We had to immediately remove that doctor from his shift and put another doctor in his place. It turns out that doctor turned out to have COVID and was quarantined at home for 14 days. But he did very well, I'm happy to report. But it was very scary for him, and as you can imagine, the team. We had to collaborate with the inpatient team. Those are the teams, once we stabilize the patients in the emergency department, we have to quickly get them upstairs to the hospital so that they could get further care. To be able to do that, we had to coordinate that care very closely with the inpatient team. We also needed additional nurses, so we were able to get some nurses from throughout the country who came to work with us because they knew that COVID was so high in New York. So they left states that didn't have cases of COVID to come help us here in New York. Triage, we had a centralized triage process. The triage process, triage, is a French word which means trier. That's how we sort, it means to sort. Before we had 2 areas for triage. During COVID, we had 1 area because we wanted to separate the patients who we suspected had COVID versus the patients who did not have COVID very rapidly. How did we manage the patients with COVID? Well, the sickest patients had to be intubated. That is a process by which we have to put a tube into their trachea, that is the breathing tube that goes into the lungs. To be able to do that, we had to do that safely and have to do that rapidly. When you do that process, the air could be aerosolized, and the virus that is inside the patient's lungs could come in contact with you as a doctor. So it is very important that we wore our PPE. We put double gloves on. We wore shields to protect ourselves so that we wouldn't get any of the virus on our face, into our eyes, into our mouth, in which case we could transmit the virus to ourselves. So we had to limit the amount of staff that was involved with the process of intubation. Typically, sometime prior to intubating, we would do what's called bag valve mask. We'd have a mask over the patient's face, and we would help compress a bag to get oxygen into the patient. For COVID patients, we did not do that because that process could potentially cause aerosolization of the virus onto us. So we had to quickly paralyze the patients. That's what we call rapid sequence intubation. We give a medication to make them sleep. We give a medication called paralytics so that they can't move, so that they can't cough, they can't breathe. And then we have to quickly put a tube into the trachea and put them on a machine to help them breathe. And we did that with a filter that you see on your right. That filter prevented any of the virus from coming from the patient to the physician. We use an instrument called video laryngoscopy. So instead of lifting up the throat to put the tube in, we would do this by video so that our face wasn't inside the patient's mouth while we did the procedure. And this was very important to do this in a very protocolized, safe way so that we would not, again, transmit the disease. You could see this box. This box was created by our team of engineers here. We would put this box over the patient's face, again, to prevent any contamination from the patient to the doctor. So this is what happened during COVID. to give you guys a sense of our normal process. During the normal process in the emergency department, if someone comes in and needs to be admitted, usually it's 1 out of every 4 patients. 25% of the patients normally would get admitted. During our peak time in COVID, we admitted 56% of our patients. So we admitted more than double the amount of patients that we would normally admit. This is how sick these patients were. Also, to show you how well we did as a hospital and as an organization, because we were so well organized and prepared for this, we had very good mortality rates. It sounds terrible to say good mortality rates, but we saved more lives on average than patients were saved in New York City. So we had a mortality, that means 14% of the patients we admitted died from COVID, compared to 32% of New York City. This is a phenomenal work, and that was a teamwork that was done by the emergency department and the inpatient team to be able to save as many lives as possible. So I mentioned to you that sometimes we could not admit every patient that came in with COVID, even if they were sick. But if they were talking, they were breathing at a reasonable rate, we were able to send them home and tell them that we will continue to monitor you from home. So we gave them an instrument, it's called a pulse ox monitor. And what we would do is we would call them. We would call them the same day they went home. We would call them a few days after, and we would see how they were doing. We would make sure that they were doing better. We would give them recommendations in terms of what medication to give, how to do breathing exercises, how to turn yourself around in your bed if you weren't breathing well to get as much oxygen in your lungs as possible. And so we were successfully able to help patients recover at home who had COVID. A few patients had worsening symptoms. So if you look at this dashboard, you would see on this particular dashboard of the 48 cases that we were monitoring, 2.1% had worsening symptoms. Those patients, we asked them to come back to the hospital and we would admit those patients. So, switching gears, fun facts. What is it about COVID that led to this? And how did we get here? Some of you may know that the virus is suspected started in China, and it was associated with a particular food market, fish market, a seafood market in Wuhan, China. Why did that happen? There are some theories, but there are also some facts, scientific facts, and we're learning more as we go. And it goes back to the bats. What is it specifically about these flying mammals, the only flying mammals that's associated with COVID? What we've learned is that bats are very resilient, and evolutionarily, they've survived. They live longer than what would be expected for flying mammals with high metabolic rates, who use a lot of energy. We would expect that their life expectancy would be a lot lower than what we observe with bats. So what's so special about bats? What we've learned is that bats do not respond to viruses the same way that humans and other mammals do. Typically, if your body sees a new virus, such as COVID, it responds with what our system of immunology respond with an immune response. It's a normal response to try to attack the virus and kill the virus. Well, bats, when they're attacked by a virus, they don't have the same immune response. They actually have a dampened immune response. In some cases, they actually don't even respond to the virus. And so then the virus says, well, my job is to enter your body, to become a host into your cells, to destroy you, to kill you. But with the bats, there's no response. So then the virus tries to mutate, tries to become stronger, it tries to kill that bat. And still the bat does not respond. And so what happens is you create these stronger super viruses in the bats. So the bats become a reservoir of these viruses. And then what do the bats do? They fly. They fly at night. They have excretions of droplets of stool. And those droplets come in contact with livestock, with other animals in the wild. And that's how bats transmit super strong viruses. And then humans consume, sometimes in certain cultures, consume the actual bats. Sometimes they consume other animals that have been exposed to contamination from the bats. And so when a patient is exposed with COVID, because we've never seen that virus, some of us, the younger people, respond in an appropriate, right amount of immune response to kill the virus, to prevent the virus from entering our cells, replicating and destroying our cells and destroying us, killing us. Older folks or folks with other medical issues respond inappropriately. They respond too much. The immune response goes haywire in an attempt to try to kill the virus. If your immune response responds too much, it actually has a detrimental negative effect on your body. It overwhelms your body. And that is what kills our patients with COVID. It's the immune response that is too much for the body. And it attacks the lungs specifically, it attacks the heart, the brain. It causes us to have clots in our body, clots that are not good because it can lead to strokes and other conditions in the lungs, such as pulmonary embolism. So that is what is killing us with COVID. So what we've learned from that is we try to block the immune response with different, what we call immune modulator, anti-inflammatory medications. So that is what is being studied, along with studying vaccinations and how we could prevent further spread and getting COVID in the first place. So a lot more very exciting research that is being done on this topic. So switching gears a little bit, we discussed a little bit about the disparities and who got impacted by COVID. And there's a lot that we need to learn about disparities in healthcare. We know that there are certain segments of our society who do not receive adequate healthcare and do not get primary care, they may not have insurance, etc., and leads to bad outcomes. For COVID, we saw that compared with non-Hispanic white patients, African Americans had 2.7% times the odds of hospitalization. Now, if you just stop at the study, you don't learn enough, right? You just think, well, African Americans, for whatever reasons, got COVID. But you really need to understand the context. Otherwise, without context, this could perpetuate harmful myths and misunderstandings of the differences of why people of different socioeconomics and racial background would get the disease. This other study in Louisiana found that 76.9% of patients who were hospitalized, and 70.6% of those who died were Black, compared to 31% of the patients in that general population. But what they found that Black race was not associated necessarily with higher in-hospital mortality than white race when you adjusted for differences in social demographics and clinical characteristics. What are the clinical characteristics? Well, if those particular Black patients had more diabetes and hypertension to begin with, they did not do well with COVID, as we discussed, because their immune response did not behave in the same way that it would do for people who are healthier. So a lot more needs to be studied on this also. So currently in our emergency department, as we mentioned before, we have had a great success in terms of COVID. We're seeing less and less COVID patients, but we're also seeing less and less patients in our emergency department overall. Patients are sick and afraid, despite being sick, to come to the emergency department. And patients are sick with heart attacks and strokes, and I'll show you some data, are afraid to come to the hospital because they're afraid that they're going to get COVID. So during this pandemic, we've actually seen a decrease, about 50% decrease at Lennox, and we're seeing this nationwide, we're seeing this worldwide, where people are afraid because we've told them to shelter in place, stay home. They're very afraid that they're going to get COVID if they come to the emergency department. So this is a big public health disaster that we have to address. So how we're addressing this, we'll discuss this. But as you can see also in the graph, as I mentioned, we're seeing less patients coming in with chest pain. So that means that patients are staying home, and some of them are dying of heart attacks at home. Same thing with stroke. Our stroke volume has gone down during the pandemic. Some of the volume you could see in May is starting to come back up, but it's not quite at the levels as you could see compared to the months of January and February before the pandemic started in New York. So this was a big concern of mine. So I wrote an editorial piece in the Wall Street Journal that was titled, "Is Deadly to Fear the Emergency Department?" And shelter in place doesn't apply if you're having a heart attack. So part of my job as the chairman of an emergency department is also to make sure that the public knows the right care will be appropriated to them in the emergency department under the right circumstances. And that is very important if you're having certain symptoms of chest pain, if you have neurologic symptoms, that you have to come to the emergency department. So this article, which is editorial, was helping to promote this fact that patients are not coming, and that this is not necessarily a good thing for certain patients. So we hope that with a lot of this marketing that this would change. This is a testimonial of a patient who was afraid to come to the emergency department. After a month of strict social distancing at home, he had very high anxiety about coming to the emergency department for his abdominal pain. His partner happens to be a doctor who used to work for us, called us and told us, and we told him it was very important that he come and that we would make sure that he would be safe, that he wouldn't get COVID while in the emergency department. He in fact came, and we diagnosed very quickly that he was having appendicitis, that is inflammation of the appendix, a part of the colon. Had he not come and stayed home, he could have had major complications and even died from this. We were able to give him IV antibiotics in the emergency department and send him home with oral antibiotics for 10 days because we caught the appendix, the inflammation, the appendicitis very early, and he did very well. And he sent us a letter to thank us for the care that we provided. So we need to do more of this. So what we're doing right now is we are to keep patients safe because now we're back to working in one emergency department. We have a process, the triage process. You can see the arrows that come from where the patients walk in to make sure that we separate patients with any kind of respiratory fevers, any signs of COVID from other patients who do not have COVID. And we're letting the public know that it is safe to come back to the emergency department. So this is propaganda that I helped create with the system to get the message out that if you're having an emergency, you have to come to the emergency department, and that we will keep you safe. We will take temperatures and monitor you and do screening. These are things that may be done in the future if you go out to a concert. They do this in Asia. When they reopen the schools, they do this in Asia also. My sister works as a teacher in Asia. They monitor you for symptoms before you enter a building. So if you're the patient, we'll know immediately if you have a temperature, if you have other symptoms of COVID, we'll separate you from the other patients. If you're a visitor, we'll do the same thing. And if you're a visitor with a fever, we will make sure that you get the care that you need, and you may not be able to stay in the hospital. You may have to go seek medical care outside the emergency department. Everyone is wearing a mask. We have, since COVID, required that all staff wear masks at all times, and that patients also wear masks at all times. So the emergency department is safe. We're keeping it squeaky clean. We're keeping, that's our propaganda. On every bed now, we put that just as you go into a hotel room to give you the confidence that the bed that you're in has been cleaned by CDC guidelines to make sure that you're safe. So I thank you for your time. I'm gonna stop sharing the screen. We're gonna open for questions. I hope you learned from this. I thank you for the opportunity to address you, and I hope that you have a productive, very fruitful, and that you learn as much as possible during this summertime. So thank you.
So do you see the chat panel?
Yes.
So I'm going to open it up now. Questions will flood in very quickly, but just answer what we'll just answer what you can get to. That's all.
Wonderful. Okay. Okay. Yes, the chats are flying in. Very good. I'm going to start from the top, and we're going to see how many we could get to. So you said that the bats do not respond immunologically to viruses. If so, why would the virus need to mutate to become stronger? Very, very good question. So what the sole purpose of a virus is to enter the host, to enter the cell and to destroy that cell. For whatever reasons, and we don't know all of it, for whatever reasons in bats, they're not able to successfully do that. The bats just basically carry that virus, and the virus just sits there and tries to mutate and tries to penetrate that host, that the cells of the bat, but it's unsuccessful and it's unable to do that. But at the same time, the bat is not actually killing the virus. So it allows the virus to become strong. Hopefully I've answered that question. Okay, so next question. Are you going to make permanent changes the way your ER operates based on the lessons you've learned from COVID? Absolutely. This is a very good question also. And I think that life has fundamentally changed for a lot of us. And there are things that have changed in healthcare in general. So one of the things we mentioned was the fact that we sent some of the patients home, despite the fact that they were sick. So I think through this, we've learned that there are certain patients, maybe they don't necessarily need to be admitted, and that we could send them home, and through telemedicine and through other mechanisms of monitoring them at home with the technology that we have, that we could continually do that. I just met yesterday with a startup company. I work with a lot of startup companies. I'm very much into technology that is looking for ways to do blood pressure monitoring, weight, pulse ox, temperature checks, being able to see in someone's throat, in their nose, in their ears from the home. So I think these are things that technology that was going to happen, but COVID has helped to accelerate the fact of being able to do telemedicine very successfully. So that's one thing. In terms of the emergency department, we realized that we can no longer have spaces that are open spaces. So we are in the process of looking to do some construction. We anticipate that in the fall, we may have a second wave of COVID and the flu. And we want to do everything to maximize the safety of the patients. And so we are looking to do more private rooms to be able to do that. And I think that's going to also help with other diseases that could be very contagious, such as the flu, TB, etc. We always knew that we didn't have enough isolation rooms. So that's something we're looking at. I think also it's going to be moving forward, patients will always wear a mask, and doctors and nurses will probably always wear masks when they're taking care of patients. So next question. As a chair, how did you manage the mental health of health professionals taking care of COVID-19 patients? You guys are asking absolutely wonderful questions. This was a big issue. As I mentioned, this was very stressful. I had multiple patients, doctors and nurses, I should say, who came to my office very stressed, crying, that they were afraid. They were afraid to manage patients with COVID. They were afraid that if they got it, they would go back and give it to their loved ones. You know, as a chair of the emergency department, you're expected to have all the answers and all the right answers. But what I learned through COVID, I've also changed, and I learned that we don't always have the right answers. And I just had to be supportive. I had to be supportive. I had to ask for help. And so we, as a large healthcare organization, we had we had a lot of support from mental health specialists and psychiatrists and psychologists who actually weren't working because they weren't seeing patients in their office. And so they were amazing resource and support for us, and that I was able to refer some of my, my nurses and doctors who were struggling, and staff members who were struggling with this from a mental health perspective to get the help. I also did a lot of one-on-ones and group conversations with folks. I had small group sessions to check in on my providers, to just ask them, how are you feeling? What are your thoughts about COVID? How is this impacting you? And then also emphasizing to them, if they saw their peers or colleagues were suffering or weren't doing well, that they had to report this in and that we would get them the help that they needed. But this is an ongoing thing. I think that we are still suffering from the consequences of COVID, having to see so many people die or so many people be so sick and not know if they would live is very, very stressful for us. How long can a patient be intubated? Wonderful question. You could actually be intubated for a very long time. You could be intubated for the duration of your life. Some of the patients who survived COVID survived, but we were unable to, what we call extubate them, remove the tube from their throat. So we had to do what we call tracheotomy. You put a hole here, and you put a permanent tube in their throat and keep them on a machine. The reason this happens is some people survive, but their lungs become so damaged from COVID that we're not able to pull the tube out so that they can breathe on their own. So they're permanently being ventilated from a machine to get oxygen into their lungs to help them continue to survive. This is also going to be another public health challenge for us. We may have people who survive COVID, but are not strong enough, their lungs are not strong enough for years, and they could be on a machine for years. There was a recent report of a young person who had COVID, who got a double lung transplant. So she had to get new lungs because her lungs were so scarred from COVID. So what are the chances of patients dying from lack of oxygen during the intubation process? You know, COVID has changed a lot of what we learned. We have seen patients, normally your oxygenation should be anywhere from 95 to 100%. We could tolerate oxygen as low as 90%. If you go to Denver, if you go to a place with high altitude, you can have a lower oxygen. If you're a young, healthy person, you could tolerate oxygen rate even lower. With COVID, I saw older patients who had oxygen levels of 70, low 70%. This is critically dangerous. And if the person is not intubated right away, the vital organs, their brains, their heart, will not get the oxygen that it needs. So that process, when they get to that level of 70, 80%, we have to intubate them immediately. In the emergency department, sometimes we're intubating 2 or 3 patients at the same time. And that's why I mentioned to you guys it was so important that I increased the coverage of doctors and nurses that I had. Next question, how do you manage the stress? Personally, for me, it was very difficult, but I pride myself, and I think most leaders are folks who are very resilient. We are folks that know how to manage stress. For me, it's exercise. I'm very fortunate to have Central Park, which is 2 blocks away. Even before COVID, I was very avid in really maintaining my health and fitness. And I think it goes along with the mental health. When you go out for a run, you get very good endorphins, healthy endorphins, eating well, just keeping a very stress-free life by maintaining your physical. Some people are spiritual, and that's something that they go to. Some people practice yoga, it's the religion. Um, some people have mentors. I have a coach, an executive coach that I was able to speak to. Family, having great family support, having great friends, really helped me to get through this. But that's something I think as leaders, most successful leaders, you will find a pattern that they're very resilient, and these are things that they often do to manage stress. So what are the hot and cold zones in the ER? So thank you for that if I didn't explain that very well. So the hot zone was a euphemism for the areas that were hot in terms of the patients with COVID or any respiratory viral fevers that we suspected may have COVID. They were put in those zones. And the cold zones were the areas where we kept patients who didn't have COVID or we didn't suspect having COVID, because we didn't want any cross-contamination between those patients. The level of questions are very sophisticated, guys. Very, very good questions. What are the CDC guidelines for disinfection? Just in general, we know that the virus, the COVID virus, is killed by substances that have more than 70% alcohol, and we also use substances that have bleach, and that's why there was all of this propaganda and public health information about cleaning your hands with alcohol and soap and water to make sure that you don't transmit the virus from your hands to your face. But in the hospital environment, it's the use of bleach to kill things. So have you been using dexamethasone? So dexamethasone is a steroid. In some cases, we did use steroids for patients, again, to manage the inflammatory response. But with COVID, you don't necessarily want to use too much steroids if the person also has a bacterial infection. So it's something we're learning. We're learning which patients do best with steroids and which patients don't. And there's still a lot for us to learn about that. So what is your favorite part of the job? For me, number one is to be able to create an environment where we could successfully save lives. And as you can see, we had a very low mortality rate. That's something I'm very proud of. The second thing I would say is I love people. I love taking care of patients, but I also love my staff, and I love to be able to be a positive force, to be a coach, to be a mentor, and to help people to be the best that they could be, to be the best performers that they could be. Because as mentioned before, if folks are coming here depressed, if they're not their best, they're not going to provide the best care. So I'm kind of a coach, a mentor. We could do it. We could do it. We could do it if we work together. And that's the positive spirit that I try to spread throughout my department, again, so that we could be the best. So I heard a rumor that the blood type influences prognosis. Is this true? There's a lot that's going on. We're learning. There is some preliminary data, maybe that there are certain blood types that are protective. There is something, it's not a wild speculation. There's something to that in your blood type. I study, and I'm very passionate about sickle cell disease, which is a disease that impacts mostly people of African descent. We've learned that people of African descent who have sickle cell trait has some protective mechanism against malaria. And so there is something about our blood types or blood shapes that do in fact confer some protection against certain diseases. So to be continued, we have a lot more to learn, and we're going to continue to look into this aspect of the blood type. That's a very interesting one. The next one was thank you for an incredible lecture. Well, thank you guys for participating, and thank you for being so engaged. So let me see if I can get the next question. What has been the biggest struggle while dealing with COVID? So, you know, I think the struggle was this was an unknown. This was something we didn't expect. We didn't know what was going to hit us. I'll just share a personal story. I just remember being in Paris, February 10th to the 14th to celebrate my best friend's 50th birthday, and it was just myself and my wife and my best friend and his wife, just the four of us. And they peppered me with a lot of questions about what's going on with COVID. Should we be worried? I said, you know, we should be worried, but quite frankly, I think we need to worry more about the flu. It was flu season. I think, you know, we've dealt with a lot of other SARS and a lot of other viruses in the past, HIV, Zika, you name it, we've dealt with, you know, storms. I think, you know, I said, we're going to be okay. Again, it was my positive thought and my resilience. But I really didn't know that this would be the pandemic that it turned out to be. And I think a lot of us in healthcare, if we have to be honest, didn't really know that this would turn out to be what it was. So I think that was the biggest struggle, the biggest challenge, to deal with the unknown, to deal with a virus that we've never seen before. And, you know, we planned for these things. Even before I left for Paris, we did a drill in the hospital. I convened a drill. So I'm part of our emergency management preparedness to make sure we're always prepared for things like this. But even our drills didn't prepare us for what we saw. But we've learned a lot. And I think if we ever are confronted with this again, we're better prepared. So next question, what advice would you give places with the current spikes in Austin, Texas? I would say that this has been a real thing. If you came to our hospital during the COVID crisis, you would see that we had two morgues in the back of our hospital. This is because we were overwhelmed by the amount of people who died. Despite the fact that we had good mortality rates, people died at rates that we've never seen before. We did not even have enough space in our morgues to contain the patient. So we had to get 2 additional morgues, and we didn't have space to put it even inside of our hospital. So there was a reminder every time we walked out of that hospital, every time we came in, we saw the morgue. So we knew the impact that COVID had. This is not a message we necessarily want to promote, but at the same time, we would like for places like Austin, Texas, Arizona, places that are not or did not take this seriously, to know that this has tremendous impact on lives. And even people who survived COVID, they went through a lot to survive it, and they still have healthcare issues and challenges while surviving it. So that's the message I think as leaders we need to get out. That's why I wrote that editorial piece, to really get the message out about the impact of COVID, the unattended consequences of the fact that people are dying, not because they have COVID, but because now they're fear of coming to the hospital because they don't want to get COVID, and they're dying of strokes and heart attacks. So I think leaders need to get the message out that this is serious. Have you guys shared this tactic with other hospitals that are currently hostile? Yes, so we have. And during the pandemic, we had other hospital organizations. I led a tour of hospitals from Interfaith, from different places, Intermountain Hospital, different places throughout the city. We collaborated, we talked with folks throughout the country. We had the department, I see Dr. Bookfar and his department did a wonderful job of reaching out to folks in China and to learn what they learned. And COVID has really brought the medical community much closer together. So there's a lot we need to keep sharing, and we will continue to share. How has your staff been able to stay positive during this time? I think it's a lot of the support that we receive from the public. The 7 o'clock clap that you guys have probably participated in has been a very wonderful in terms of support. Food, donations, all of these things have really kept us afloat. Other treatments, other steroids for treatment. So steroids is something we're still learning, but there are what do we call the interleukins, the things that cause inflammatory process. There's some research that we're looking at in terms of blocking the immune response. There are antivirals that we're looking at that have had and shown some promise in terms of shortening the duration of COVID. We are thinking that we're going to have to treat COVID with a cocktail of drugs, just as we do with HIV, because the virus mutates. So you're going to have to attack that virus with multiple viruses. We're antiviruses, I should say. We're looking at the plasma of patients who've had COVID, because in that plasma, they have the antibodies that will fight the virus. So we're looking at if we give that, if you make a blood donation, we take that plasma that has those antibodies and we give it to a patient, that will give them a fighting chance against COVID. We've also learned that there are certain medications, despite the hype, that have not worked. And we're also getting the message out that these medications can actually be detrimental. So we're not recommending, and the CDC is also not recommending. What guidelines did you put in place to prevent staff spread of COVID? The PPE we know works very effectively. I was involved in taking care of patients, not only here at the hospital, I also work in urgent cares in Queens, where I swabbed. I had people with COVID cough in my face. I intubated very sick patients with COVID. But the mask, the N95, the PPE, a mask over it, a shield, and a protection helped a lot of us. The doctors who worked in intensive care units, who were exposed to the sickest of COVID patients, a lot of them, a majority of them, 90% plus, did not contract COVID. And that was because of the PPE that we wore. And so we know the spread, not only staff to staff, but also in the public. That's why the mask is so important. Good morning. What symptoms did you look for to admit patients rather than send them home? So we had guidelines for the patients that we sent home. There was a protocol. Their oxygen level could be lower than a certain level. We walked them around. We made sure they didn't get short of breath. We did many different things. But to admit them, we looked at the blood work. I didn't show you guys, but we had order sets, and we had to see what their white cell count was. There were other markers, inflammatory markers. If they were very high in their blood, we knew that these patients were very sick and we would have to admit them. Very good question. To what extent should U.S. citizens take precautions towards COVID? Well, I think not traveling is a very good first step, and also not traveling to hotspots that have COVID. And I also think that while we want to get out there and interact and go see grandma and grandpa we haven't seen, we have to take precautions. We have to continue to socially distance. Testing is available now. So if you absolutely have to go see someone, make sure you get tested. Make sure you don't have the virus, and then stay quarantined prior to the time that you have to go visit.
Yves, how you doing?
We're doing well. I love this. I could keep going on. So you let me know.
We, in the interest of time, we're going to start this live surgery session next. So I wanted to say thank you so much. I think that was obviously phenomenal. You have, great responses here. Much thanks.
Well, thank you all. Thank you for organizing this. Guys, enjoy your summer. Keep learning. Keep asking these wonderful questions. Thank you.
Great. Thank you so much.